Everett. I'm the coordinator of the Clarence Schools Family Support Center, and I'm just really thankful that we have two, very well established, well qualified presenters today to come in and talk. So, and I appreciate those of you who are here.
I'm Penny, I'm a social worker at the Family Support Center.
I'm Kenzie, I'm going to be at the Family Support Center.
Where is this place exactly? Is that the old Pizza Hut building area? Is that where it is?
I don't even
The
know
old
where that
library.
is.
No, it's the old library that
So-
everybody says looks like a Pizza Hut.
That's
That's what
what
it is.
So we are,
That's how it is
so we are
described.
currently in the middle school.
Sorry, in the middle school.
Clarence Middle School, yeah,
Oh.
but, so they're building, I don't know if you've driven
Yep.
along Main Street,
The
so
high
where all
school.
that new construction is in the high
Ah,
school is
that's
gonna be
where
our
you're
new
in.
office. So we'll have, in addition to just our staff offices, we'll have two open, offices that can be utilized to have outside clinicians and therapy providers come in to provide support, so that way community members, let's say if they needed support, whether for mental health or other supports, we can bring in outside providers to utilize that as almost like a satellite office space. Because again, obviously there's providers operating all over Western New York, and some of them are further out in the city or in other areas. So for a lot of our students in particular, especially if they're involved in extracurriculars, things like that, it can be really challenging to fit in, let's say, a 6 o'clock appointment with a therapist after school when they have maybe transportation concerns, or maybe they have a bunch of extracurriculars. So part of that new office will be able to be utilized. So if a student, let's say, is meeting with Jenna or meeting with Amy or one of our other outside providers, they can potentially use that space during the school day. So instead of having to drive across the city or things like that, the goal is to utilize that space as almost like a one-stop shop for all the supports that we can provide Clarence as a community.
And are these services at no cost to students and families, or it just depends?
So it just depends. So we have grant money right now, which is what helped fund this event. But if you wanted, let's say, as a community member to meet with an outside provider who was utilizing our space, you would just go through your insurance as you normally would for like any other therapy. But for things like support groups, other events that we might put on, and then Penny as a social worker has the opportunity to meet, if there's a family or a student that might have kind of some short-term needs in terms of mental health or just counseling, that's something that we can provide definitely at no cost, but it would just be a situation where, because we get referrals from from community members, from school counselors, psychologists, etc. We're approaching 300 referrals for the year, so there's no way we can manage 300, a caseload of 300 people long term. So a lot of what our office does is, okay, let's say as a parent, you have a child that is in need of mental health support, let's say, we would then, Penny might meet with them a few times, we would link out and say if it was a situation where there were concerns around body image, eating disorders, I might shoot Amy an email and say, hey, I have a student here who is really in need of this type of counseling, link that parent with them, and then they would kind of figure out the payment structure from there. Yeah. So anyways, that's a great question, thank you.
Can I ask a quick question? Is it 300 referrals for 2022 or the academic year?
The academic year.
Oh, okay.
So-
Still that's high, but I was afraid
Yeah,
it's 6
so,
months.
So I must see a backlog you're working from.
what's that?
So you're kind of working from a backlog, are you overwhelmed? Is that a lot?
I think it goes in phases. Like last week, we probably had 10 to 15
Yeah.
referrals because it's right before summer and families and
So-
schools are like. So it goes in phases.
I wouldn't say we're
You're not swamped.
overwhelmed or
It
swamped.
goes in phases. We're kind
It's-
of.
It really depends on, like I would say what happens is that,
I was just thinking with the COVID, has there been a backlog because of COVID?
well, definitely, I think they would be able to speak to that as well. Most of the mental health providers in the area have wait lists.
Yeah, that's
So,
what I heard.
which is one of the reasons why we want to hold more of these types of events, because as a parent, as a student, as a community member, we can, let's say, know the warning signs of particular mental health issues, or if we can provide, if there's families who have food or housing insecurity, which does exist in Clarence, if we can provide them with the resources before it turns into a crisis,
Yeah,
then our office isn't gonna get overwhelmed.
yeah.
And then those therapy providers aren't gonna be inundated with those wait lists, hopefully, because they'll be able to deal with a lower number of crisis situations,
Yeah.
and hopefully some of these preventative actions will work, so. But yeah, before summer, before like holiday breaks, beginning of the school year, any of those like transition times of the year, we definitely see like an uptick in
Yeah,
referrals.
sorry, last question. You go through the summer, you're like all year, right?
Correct.
We are paid throughout the summer, like it's additional hours, it's not structured time.
Oh, got
But
it.
we're gonna make it Tuesday, Wednesday, Thursday, and that way we're maintaining referrals, we're coming up with more systems and structures for the fall. But then we also have a summer and have 4-day weekends to kind of catch that break.
Yeah,
Thank you.
yeah, for sure.
Sorry.
That's okay. I'm Amanda Jasper. I teach in Greenfield at the middle school. I'm actually here as a parent though.
How old is your child?
I have
Children.
3, but one in particular that I'm here for is 11, just turned 11. And he is struggling with some body image issues, and he's a wonderful kid, and he's got an anxious streak, and he came out during COVID, and now it's kind of like flaring again, and it all is revolving around food and how he looks, and so this is like right on point for me. So,
Glad you're here.
yeah.
I'm just a dietitian who's let her accreditation lapse her forever, so I'm like, I just need to come and see what's current in the field and what's going on, and so I'm just here to learn.
So where did you practice?
BYU. I never practiced, because my husband was going to school at the time we were at BYU, and there was no job available. I just took whatever because he was still in school. And by the time a job came available, we were getting ready to leave to Singapore for a job I was taking there, so I had to turn it down. And we've had kids, 6 kids since then, so, yeah.
You've been good.
Yeah. So, but I want to know what's current, what's going on, and so that's why I'm here. And then if I can help, if I know of things, I mean, you can always tell people too, you know.
Yeah.
When you hear people, you know, family members or whatever, you can spread
This
the
is
word.
good to know. I thought you guys were shut down during the summer.
No.
So, because I think school year, do you know, what I
Yeah,
mean? People
yeah,
get school
for
year academic calendar, so.
We have some events coming up in the summer too. We have the Youth Bureau collaborating for a documentary Angst, which I think was shown in Niagara Wheatfield.
Is that, what's at the end of the summer?
Yeah.
Oh, that's on my calendar. Is it 2 nights
Yes.
of the same thing?
Yep,
Okay.
so, August 16th and 18th.
Oh,
So we're still here. Use us. Definitely.
Yeah.
yeah, well, good, good. I happen to be a teacher.
Okay.
And I've worked with, I'm in Lamport High School, and I was also at Niagara Academy, the special ed population, and I do know that, you know, eating disorders are multifaceted, and, you know, it's bright. You mentioned your son, and I think most of us think girls, and coming to this, there are a couple boys I have right now that a couple look like they're a little on the skinny side for boys, you know, and I serve a lot of food in class, and a lot of times they're never taking anything, so, you know, so.
Just to be aware.
Yeah, this is professional development for me. Even though today was my last day of class, I'm like, okay,
Oh,
this is
exciting.
important. So,
Well, thanks for coming.
no, this is an important topic, and I think COVID either manifested some kids' issues, or they started, you know what I mean, I think.
Absolutely. I mean, eating disorders itself thrive in isolation, and part of COVID was isolation, and still is when people get sick, right? And I had read a statistic about 14-year-olds specifically, since COVID, it went up, the eating disorders diagnosed went up almost to 50%, I believe. So in just 14-year-olds. So the period of adolescence is so important for adults and people in general, just to kind of be aware of what goes on with their brain development, how they're seeing the world, and how they have control over their own bodies or what they can eat. And it's a really difficult time, for sure.
So, I I would encourage all of you to like stop us if you have questions. You don't have to wait till the end because the group is so small. We have like a bunch of information to give you, so we'll do that in as briefly as possible. And then really just open it up for discussion. But again, as we're going through, please feel free to like say, stop, wait, I have a question. And we'll just stop. So, my name's Amy. I am a therapist out of Tonawanda. I own my own practice. And I specialize in eating disorders from school age all the way up to seniors. I also work with anxiety, depression, trauma, transitional things, really just an array of different mental health disorders.
I'm Jen Budania. I'm a registered dietitian, and I also specialize in eating disorders. I used to work at Clarences Eating Disorder Center locally, which is a day program for people who are diagnosed with eating disorders as recovery. So I have a lot of hands-on experience with the higher level, higher crisis people who struggle. Now I own my own practice, which is a private practice for one-on-one nutrition counseling. I have seen people anywhere between the age of 9 years old and 55 years old of all different kinds of diagnoses. And what I really want to start working on, as I'm new in private practice, but I'm not necessarily a new dietitian. I really want to work on more prevention and mindful education about nutrition so people really know how their bodies work, because as we're all adults, we've all lived a long time, right? We probably have been through so many different times where we hear, oh, this diet, oh, that diet, right? And now that we have the social media aspect to it too, it's just a lot for everyone to kind of understand what's nutrition myth and what's nutrition fact. So that's what I'm really big on, is kind of clearing out that pathway.
So, I'll kind of just start as like what my role as a therapist is, specifically with eating disorders. And we'll get a little bit more into this as we go. But from the very first session, if someone comes to me for an intake and says, you know, my kid is struggling with disordered eating, or I'm struggling with disordered eating or something like that, I get a full history, a full background. I would say 99.9% of the time, maybe even 100% of the time, there are co-occurrent diagnoses, which means there is an array of diagnoses that go along with this eating disorder. It's never just an eating disorder. So I make sure I'm doing a full assessment of like what else is going on. I work very closely with family members, another support system if that's what it is, whether it be a teacher, a friend, whatever. Dietitians, and then medical doctors if they are medically unstable and are being overseen by a doctor, then I'll connect with that person as well. So really what I focus on with eating disorders, regardless of the place of recovery they're at, is learning and teaching about positive body image, and then also learning coping skills to use during mealtime, before mealtime, during triggering situations that might trigger them to start restricting food, things like that. Psychoeducation for families, and then providing support throughout the whole process, because it's very stressful, and a lot of parents are like, why won't my kid just eat? Like, I don't understand what's going on. So giving that psychoeducation piece and continuing to support throughout the entire process. It could be a year, it could be 10 years. It kind of depends on where you're at and what that stage of recovery looks like. Hi, come on in.
I'm late and I'm not registered.
That's okay.
Oh, that's okay, come on in.
We just started, so we're timing. So my name's Amy. I'm a therapist. I work with eating disorders. So we were just kind of going over what my role is as a therapist.
And I'm Jenna. I am a registered dietitian, and pretty much I've been working with eating disorders for the last few years, and I just started a private practice, and I'm really starting to get going in our community.
So something important to remember, and I get a lot of frustration from parents with kids who it doesn't feel like or look like they're making progress. And something to remember, and I have to kind of like continue to talk about this, is some diagnoses need to be treated before the eating disorder can be treated, which is super frustrating for a lot of people. But it's, you know, whether it be safety or suicidality or trauma, sometimes that has to be treated first. And we stabilize that, and then we work on the eating disorder, or vice versa. So it kind of depends on the person as an individual. So some common eating disorders that I'm going to touch on today, some I'm sure you've heard of, some you haven't. Again, please feel free to stop me if you have any questions. So bulimia, that consists of, and you can mention anything that I don't mention, just like jump in. So bulimia, that includes binging and purging. Anorexia, we have the restricting type or the purging type. Pica, I don't see that a lot, to be honest. That's just eating like non-food items that don't have any type of nutritional value, so like chalk or, I don't know, anything else you can think of, I guess. Binge eating disorder. So this one is very similar to bulimia, but it only is the binging piece. And then something to remember when we're talking about binging, like there might be.
Sorry, just a quick recap.
Oh, that's okay.
Thank you.
When we define binging, it's something, it's not like, oh my god, I ate a whole box of macaroni and cheese today, I like binge. It's like, I ate 5 large pizzas, 3 bags of chips, and 17 hot dogs. Like, it's like an obscene amount. Would you agree?
Absolutely, yeah, it is, it's kind of defined as more than you would have in a typical serving of one box. Really isn't that outlandish of a serving, so yeah, absolutely. I've heard people say like through DoorDash or Grubhub is really common because it's isolations and it'll be in a few different places, a few different meal packages, so that would be classified as a binge.
Yep. We also have rumination disorder, which basically someone will be eating something, they regurgitate it, they chew it, swallow it, regurgitate it, and then either spit it out or swallow it again. To be honest, I see this a lot with people who do like bodybuilding shows. Like they will, I've literally seen this, they will like eat a French fry just to get like the taste of it, chew it, and then spit it back out. And then orthorexia, this is considered another specified eating disorder, so it's really just an obsession with healthy food and a healthy lifestyle. So these are the people that you would see like those influencers on TikTok or on Instagram that are literally only posting things about their bodies, like clean eating, being fit, being at the gym all the time. This is, in my opinion, more of what you would see with men. Would you agree?
For like,
Orthorexia.
I feel like I have seen it in a balance of both.
Oh, really?
I've seen it in a balance of both because I have had patients who had an orthorexia, it's not DSM, right? No, it's, so orthorexia is a term that's kind of just a distinguishing term rather than an actual diagnosis, like diabulimia would be. So what diabulimia is kind of a distinguisher of someone who has type 1 diabetes, who is manipulating their insulin and their food intake to lose weight. So that would be under the bulimia category as well. So I've seen orthorexia, and that's interesting.
I see it mostly in men, but again, this is, and you probably not care about this, but when the new DSM comes out, they're trying to get this as an actual diagnosis instead of just the, anyway, that doesn't matter. So, any questions on that? That was a lot of information. Yeah.
Can you also describe
ARFID, do you want to touch on
Yeah,
this?
so ARFID is avoidant restrictive food intake disorder, and I do see people who have ARFID, and I work close with the doctors at that point. People who I have seen who have been diagnosed with ARFID have, a lot of times have a co-occurring disorder, or co-occurring autism as well. That's really common as well, and it's also more common in children rather than adults. Adults can have it, but it's more common for us to see it in children as well. And how it's different than anorexia, so anorexia, people will restrict their food, which means that they will have a lack of food, they're malnourished, right? Avoidant restrictive food intake disorder is a very similar thing of malnourishment and restricting, but it's not because of their body image and it's not because of their weight. It is mainly sensory. It's mainly texture, smell, how it may make someone feel. So if they eat and they feel bloated, that's not a nice feeling, especially with someone who has a sensory issue. So that may connect with that. Did that answer your question? Do you have any more questions? Okay.
Anything else before we finish? So just some quick risk factors, biological, cultural, psychological, and social. I'll just touch quickly on this. So what I see a lot is the biological piece, which is having a close family member with an eating disorder, history of dieting with families, and I know for me, and I'm sure there's a lot of us here, like my mom grew up on Slim Fast, and that was always in our house. That was a huge thing of like, I was just like big when I was a kid. So those crash diets and things like that, Weight Watchers, Whole30 now, like all of those things that are really, you're restricting food that you eat, those are risk factors for kids in your home. We just talked about diabulimia, so diabetes. A lot of people who experience eating disorders also experience significant trauma, whether it be physical, emotional, sexual, and that's when we talk about, I'm sure you've heard like, oh, eating disorders come from people wanting control, which is sometimes true, that's not always the case, but a lot of times with trauma, this is where that comes from. I also see a lot with individuals who have trauma, either binging or the anorexia and bulimia, because they either want to be bigger because it protects them, or they want to be very small because they can hide. So that, again, kind of depends on the trauma.
Can I just ask a question? So this seems like it doesn't seem like there's one of these, the list of categories for the illnesses that you listed that is not multifaceted in its approach and for treatment especially. So I'm looking at you like in private practice as a dietitian. How do you, it seems like you can't do it alone, is what I'm thinking. How do you coordinate, and how do you, when a patient comes in, you say, you need a therapist as well, and how do you do that? Do you have a network of people you work with and everything, so everything gets coordinated?
Absolutely. So really good question. It's a multidisciplinary approach. You can't recover from an eating disorder without eating, and eating is one of the biggest things that is an obstacle for someone with an eating disorder, whether it's any symptoms. So it's not just entirely physical, it's mental as well. So I have a whole list of dietitians that I know who work with eating disorders. I have a whole list of therapists and doctors that I work with, and I'm always conferencing. I'm always case conferencing with their doctor, their therapist, if they have a specialist doctor, and if they're a minor, their parents as well. Because there's the therapeutic side that's going on. If there's medication involved, there's that psychiatry or whoever is dosing that medication. If weight is needing to be monitored, it doesn't always need to be monitored anymore. That thought is changing. But say if someone is at an unsafe low weight, I would have to communicate with the doctors very frequently. And I also have to communicate with the therapist, the doctors, the psychiatrist about an amount of calories that person is eating just to keep them a functioning human being.
So for instance, if she wanted to get help for her son, she could just come to you and you would help connect her with all the other people. But that would seem overwhelming trying to find 5 doctors or whatever. So she could someone could just come to you and you would connect.
Absolutely, and it's such a small community because the eating disorder community is so underserved. It's so hard to find a clinician or a physician that really has been trained and has the experience, because we don't learn about it in school as much, right? As a dietitian, I didn't really have a lot of eating disorder academic training. You have to seek it out after you graduate. So I am finishing up a certificate in eating disorders through the Plymouth State University college of just being a medical professional in the world and treating people who have eating disorders as well. So there's a lot that goes into it, and when you find those professional people that work with people who you work with, you stick with each other. So I am always in communication, and I can always kind of get someone in. So the wait lists are so incredibly long, especially for a residential facility, which is a 24/7 facility, or a partial, which is 5 to 6 hours sometimes, or intensive outpatient, which we'll talk about in a little bit. But there's a wait list for everything.
So it seems like if I'm thinking that like her son, and she wants to do something,
I'll
it
connect
seems
with
like
everyone.
the first step would be, seems like the easiest way to get in and get all the help she needs would come to a dietitian before a pediatrician or someone else. It
Yeah.
seems like you have better connections and more know than going to just a regular doctor or a pediatrician.
And that's super interesting that you say that too, because I try to work with multiple pediatricians and therapists who don't really work with eating disorders, just to give them to red flags, because as you said earlier, there are a lot of co-occurring instances where you have to treat that before the eating disorder, right? Physically, sometimes you have to rule in an eating disorder before ruling something out. So say, for example, if a child is, we'll say, losing weight, because that's one of the most common things that people really kind of know about eating disorders is low weight. Say if a child was losing weight, a doctor may get thyroid labs, look at the blood work and see that there is nothing wrong. To have anorexia or an eating disorder that's restrictive, your labs don't need to be wrong at all. They don't reflect that at all, and it's kind of, people have told me it's embarrassing, right? Like it's embarrassing, or they know that it's wrong, but they can't help it, so they won't really talk about it until they're truly ready to talk about it, or someone notices it and say, hey, what you doing over there, right? Kind of pointing it out, because they know it's not what typical people do, and it's hard for someone to notice it when you don't know what you're looking at. Right, so I have heard of many people who've gone through the gamut of tests and then, oh, I have binge eating disorder. Okay, then you work on it.
Sorry, I was just trying to be helpful, like, where do you start? It's like so overwhelming.
Yeah.
Coming from the experience of having a child that's going through this experience, I would have said a dietitian would not have been somewhere where we could have started. Because the focus of a dietitian is all on food.
It's so hard.
What are you eating, how much are you eating, when are you eating it? And that was not at all where we could start in any form.
And it's so individual.
I think it depends on whatever, and this is just me talking from like being a parent. Whatever puts you into that space, for us it was the pediatrician. We came from a psychiatrist to a pediatrician because we thought it was medication that was causing her to not want to eat. Whatever brings you to where you need to be is the right path, in my opinion.
I also, and I can speak on that a little bit too, I have so many clients who come in and they say, I'm not ready to start working on my eating disorder, or I'll start working on body image, I'll start talking to you about food, but I'm not ready for a dietitian yet. And that's exactly it, because I think most people know that when they start seeing a dietitian, they're going to be making some changes. And once you can get your kid to go to a dietitian or adult or whatever, there are going to be changes. And I refer most of my clients to Jenna, because there is that, what I've experienced with some dietitians is it's, if you don't eat, you're gonna die. It's like the fear factor that does not work. And Jenna's so gentle and amazing that like, all of my clients are like, we love Jenna, and I'm like, oh my God, thank God. So that is true, and it's something that's really important, like really starting where the client is. If they're not ready for a dietitian, then it's off the table. So that's a huge thing.
And it'll ebb and flow too, because I've had people who may have came to me initially for something completely different, and I see my red flags and I talk with them and I ask them my targeted questions, and then I might ask, well, have you ever wanted to see a therapist or someone who specializes in help you out? And sometimes I get the same responses. If someone is not ready for that particular change, it's not the right time.
Yep. So Another huge thing that I'm sure all of you see is the social risk factor of Instagram, TikTok, Facebook, all of that. Just this weight stigma that if you are not a certain size, you're not good enough. And so I do a lot of work around that in sessions, in being okay in your body, not even being like confident or accepting, but just being neutral. And sometimes that's what recovery looks like for people, is just being like, all right, it's a body, this is it, instead of being like, yes, this is my body, I love it. Like, that's not the case for everybody, and that's okay. So I'm gonna hand these, if you can just pass these around. So this toolkit that I found online is fantastic, and it has a lot of information about what we're talking about today. So if you ever need to refer back, feel free. So what we're gonna touch on really quickly is warning signs. So if you wanna flip to page 11, that's kind of where we're gonna start. And this really has, oh yeah, this really has all of the information that you need to look for the most part.
Page 11?
Yep. So I'm not gonna read these all to you because I know you can all do it on your own. But if you wanna take a moment just to read through some of these and let me know if you have any questions, I can clarify some things for you. So obviously the main ones that you're probably gonna catch on to first is those big changes with food, whether it be not wanting to eat anything or saying, oh, I'm vegan this week, or I'm vegetarian, and there's nothing wrong with vegan or vegetarian, but coming from a kid specifically who's eating steaks every day and then they say, oh, I'm vegan now, I would just encourage you to explore that a little bit. So the main ones I want to point out are eating tiny food portions or refusing to eat, eating in secret, hoarding and hiding food. I have some clients who will hoard food in their rooms, as well as bags of vomit, which sounds really horrific, I know, but that's safe for them because they don't have to explain why they're running to the bathroom after they eat. So that's another thing to really pay close attention to. If you notice a loved one going to the restroom every single time they finish eating, like I would say within 45 minutes, probably a red flag, just something to be aware of. And any new practice with food. So fad diets, again, like deciding, oh, I'm gonna be vegan today and not eat X, Y, and Z. Those are really the main things to look out for. Any questions on that? Yeah.
Yeah, so I'm seeing a lot of, I can check a lot of these things.
Yeah.
But one thing I don't see, which makes me think he's just kind of like, this is maybe unique or whatever, but like he'll eat and then he'll like tell me I shouldn't have done that. And he has all this guilt.
Yes.
And then he brings it up again, and he brings it up again. And I need the words, like I don't know what to say.
Yeah.
Because at this point I'm like, can you go away, because you're annoying me. And I don't want to say that to myself, but,
Yeah.
That's kind of
I think
what it's like sometimes.
what I find is interesting about what you just said is the fact that he's coming to you and telling you that. Because what I see a lot of at the very beginning is like these guilty, shameful behaviors that they're hiding because they want to be as small as possible, and if they tell someone, they won't be able to do that. So it sounds like, which is great, that he's like really asking for help. And I think the main thing you can do is like provide those resources for him. If he's ready, do it.
Yeah,
Yeah.
a lot of discussion, because he's an athlete, has been about fueling your body and fueling your body with good food and the right gas, you know, instead of like crap food. And no, he is like a typical kid. He would like love to eat chips all day, you know, and not a big fan of broccoli. But, you know, like I'm always telling him, this has vitamins, this has minerals, this has fiber, this has X, Y, and Z, and this does not. And so I don't know if I've done harm by having that, like constant, you know, feedback, because I don't know what other words to use. I just feel like that's, and then also I have the mom white noise kind of thing going on, where it's like I could be saying all the right things if he's not listening to me because I'm mom. Like I don't know anything.
Yeah.
So, yeah.
Well, for him, a good place to start might be a dietitian where he can learn, okay, this is what I need to fuel my body. If I'm playing football, if I'm running track or whatever, someone like Jenna could tell him, okay, here, if you're running 10 miles today, this is what you need to fuel your body with. That would probably be the best way to start, I would say, and then transitioning to like, where did this come from? And then maybe integrating therapy. Yeah, that's just my initial thought on that.
Yeah, it seems like, and honestly, I've already asked him about seeing a nutritionist versus seeing, you know, a therapist. And because I felt like he would buy into it. He watches like YouTube shorts of people making food all the time, and I'm like, well, maybe we can incorporate that. He has an interest in making food, I will cook with him. So it's like maybe we can go from there.
Absolutely, and that is
Yeah.
actually something that's common that I'll see in people who struggle with food, is that like their TikTok For You page will have food on it. They'll seek out YouTube videos, they'll watch the Food Network all the time. And that's a really good indication on one, hyperfixation, but two, their body may not be getting enough nutrition and survival mode is coming. Right, so as a dietitian, I mainly work with kids, and I do have a gentle approach, and what I typically start off with after I just kind of like get a little info from that person is really talking about your survival instincts, your biological instincts, and then what you're consciously thinking about, because they don't really talk to each other too much. So sometimes people tell me that I hit the nail on the head with, do you feel cold consistently? Do you feel fast fullness, like if you take a couple bites, do you feel really full pretty fast? Or like, does eating before make you anxious? Does eating after make you anxious? And a lot of times the answer is yes, especially the cold feeling. If someone has I don't want to say atypical eating routine with food, so let's say if they don't really eat during the day, but they may eat more at night, or just something that's not consistently eating throughout the day, they may feel cold because their body is trying to utilize the nutrition for their heart, their lungs, their brain. So your body already kind of has an idea about how many calories it wants. It already has an idea about what it wants to be at. And when outside factors start to influence that, the body doesn't really know what to do besides keep you going, right? So I will typically tell people that 70% of the nutrition that your body needs will go to your involuntary functions. 20% of it will go to so you can like walk around and be a human, right? And 10% of it is feeling warm and toasty. So when the majority of someone's nutrition is going to your heart beating or your lungs breathing, your brain's not really getting that food to be focused or be cloudy or not be as anxious, because your stress system is kind of going haywire because it's just trying to keep your body going the way it knows how to do. There was this really interesting study, the Ansel Keys starvation study, a very long time ago. I can't remember the year, and that was the paper I was looking for that I misplaced. But pretty much what it was is that it was a group of men after World War II. I want to say it was after a war, and they did a study on what does restriction look like. It was right before World War II because they wanted to know how to help people coming out of the camps, right? So they starved these men and they lost a lot of weight, and the research came back out. So when they were done with the study and they were eating the amount of food that they typically eat, they noticed that they had higher anxiety. They were so hyperfixated on their bodies. They were really meticulous about the foods they ate, even after they gained that weight back that they lost from purposely restricting. So it's really interesting how nutrition has an effect on the brain. And what I'll see too is people who have maybe OCD, you'll have people who have obsessive compulsive disorder, and then you have people who maybe don't, but people may be thinking that they do, and they do have an eating disorder. Once they become nutritionally rehabilitated, some of those OCD tendencies may actually go away. So with nourishment, it's so particular with how the body really wants to be that when kind of wacky things are going on, you're just not the person who you used to be because your body just can't do it. So I'm really passionate about just having those conversations at whatever age that person is at a level that they can understand with, sometimes this really affects the body and this is how you might be seeing it. Does that resonate with you? And a lot of times they're like, Jenna, are you kidding me? That's how I feel all the time, right? And that's what kind of gets them motivated to start recovery, because the fear factor really does not work because they already know that. They already know that it's dangerous, right? So it's really just can I guess a couple things real quick? If I'm right, I'll tell you why, right? Because then they're interested. That was really long, I'm sorry.
Okay. Yeah, that's great.
So I'm gonna kind of skip over this slide, but you just touched on OCD, is huge, lots of co-occurring between OCD and eating disorders, anxiety, depression, which Jenna just touched on, so we don't even have to go to that slide.
Well
Do you want me to pull something up?
Oh, no. No, we're good.
Alright.
Thanks. Okay, so yeah, I have been trained, it's kind of funny, so with that multidisciplinary approach, I have been trained by a lot of therapists, and I have trained a lot of therapists as well. So like there are some things that Amy may know that from what I have talked about, or that I may know from what she's talked about, because we don't want to step on each other's toes, but in session when we're seeing these things, we just kind of already have an idea in our head about, oh, this is what that discipline would say about this, or oh, this is what the other discipline would say. So you know how to kind of give people referrals, or you know kind of what to say, and say, you know what, I think that might be a therapy thing, or you know, I think that might be a nutrition session thing, to make sure that we're on our own lanes and our own boats. So adolescence, why we're mainly here is to talk about our kids, our adolescents, or to see what's going on in our kids or adolescents, and why are they so at risk for eating disorders, disordered eating, or just kind of doing some maybe wacky things. In my practice, I'll kind of say, what are we doing that's wacky? So the life stage that they're in, they're going through puberty, right? Cisgender girls will go through puberty early as 8 or 9, and they kind of go through, and they're pretty much done at like 15, 16 in general. And cisgender boys, they are just a little bit later than that. So puberty is already a weird time with your body is changing and your brain is still developing until the age of 25 years old. So cisgender girls who go through puberty early are more at risk for developing an eating disorder or disordered eating because, one, I've been told just the attention. It's a little bit different than people who are not going through puberty at the same time. For the cisgender boys, it's a little bit later because the focus on them being smaller than everything was. So as we were saying, the orthorexia just kind of being bigger, a little bit more masculine, and being smaller, more feminine. Kids actually start understanding food and nutrition and body cues about what their parents are talking about, what their teachers are talking about, what their friends are talking about, what TV is talking about by the age of 6 years old. So statistics actually will say that 62.3% of teenage girls and 28.8% of teenage boys report trying to lose weight. 58.6% of girls and 28.2% of boys are actively dieting. And 68.4% of girls and 51% of boys exercise with the goal of losing weight or to avoid gaining weight. And just with that information, what do we know about puberty? It's for someone to grow, right? It's for someone to grow taller, to grow bigger, to get into their adult bodies, and there's just so much influence that may be that's just unintentional most of the times, right? That can counteract that if someone has that little part in their brain that's sensitive to eating disorder or disordered eating. And then Amy has already talked about a little bit about self-perception and chronic diseases as well. So that's why adolescents are at risk, mainly the life stage that they're in. They're trying to figure themselves out. You're going through so many changes. We're at risk for a lot of things just to start to happen just like anything else. And I also like to talk about the LGBTQ plus community as well. Gay men are 7 times more likely to report binge eating and 12 times more likely to report purging than people who identify as straight. And it's estimated that 40 to 70% of non-binary and transgender folks struggle with eating disorders as well. And I know that people are more accepted into coming out and being themselves now a little bit more than it has been. So in my practice, I see a lot of people who are not really the normative of struggling with eating as well. So I'll talk about, we're just going back and forth through all of this. So nutrition basics, I'll start talking about. I feel that in what I've seen, even when talking to parents or teachers or kids, that we kind of get an idea of the nutrition basics, but we really don't have the, okay, well, what is good for us? Is there a bad? I don't use the terms good or bad to talk about food because food doesn't have a moral code. Food has dietary fiber, it does not have moral fiber. And yeah, right? And what I'll say to kids is that a bad thing to do is stealing someone's money, or I'll say to adults, a bad thing to do is stealing someone's ID and going on a trip to Mexico, right? Eating a donut is not either of those things, right? And what is happening is that kids really aren't being kids when they're focused on too much about what they look like or what they're eating, and adults aren't living their lives if they're too focused about what they're eating, or if they're focused on what they look like more than what typically would be if it starts to affect their quality of life. So I always like to go through a little bit of my nutrition basics with people to talk about what the heck are carbohydrates, proteins, and fats at a general level, just to kind of get those talking points on what things actually do for your body, because I feel like there's such an it's so empowering to know what affects your body, like what makes you go, what makes you work, and what doesn't make you work. And knowing that is really cool for kids to know.
Do you ever see clients where you give them information and then they fixate on that information? Or like, you know, is it a bad thing to, at a young age, be saying, you know, let's look at carbs and what they do? I mean, I like this approach. I think it's cool. And I would subscribe to it, but I just wonder if it could turn into a fixation and an obsession.
So the answer is yes and no. And if it turns into a yes, I always say that's a therapeutic thing. Why are we fixating on that? That's also why I don't talk about numbers. I don't share weights. I don't talk about calories because that's where the triggers mainly are.
Yeah.
Not that carbohydrates are sugars that digest to give your body the energy that fuel your muscles, your brain, your cells, and without that carbohydrate, that's why you're so tired all the time, right? Or that's why you're so cold all the time, right?
I saw my son looking at food labels and I'm like, well, wait a minute, do you know what a calorie actually is?
A calorie is actually a unit it's like a chemical compound that raises your body up 1 degree, so you're to be warm and toasty.
Yeah.
And calories are data, right? It's not something to run your life. Right, so that's why I really don't focus on it. Like, I know for my data, because I know how to use it, I know how to talk with a doctor about it, I know how to give people portion size ideas if they need to gain weight, right? But otherwise, I really won't tell someone what I think they should be doing because that's general nutrition education and it's not an individual nutrition education. So I mainly, here's the basic information, here's how we combat diet culture, because cutting carbohydrates is definitely not the answer to help give you more energy. That's the opposite of what carbohydrates are intended to do, right? Like we cut carbohydrates, we're gonna be sleepy because we're not getting the energy, right? So why be tired all the time? Well, you can study for that test that you want to ace, you can get to the college you want to go to, right? Or if you're an athlete, why be tired all the time? Why be feeling so weak and just lethargic if you want to score that soccer goal, right? Like using what they want as motivation, and it's the same way with adults. You don't know what you don't know, right? And what we hear, diet culture is it's over a $70 billion industry, and what can we do with $70 billion? A lot, quite a bit. And that's just people who are profiting off of people's negative self-perception of themselves, really, right? So I really love the sheet for just that basic information. So we talked a little bit about carbohydrates. They're not bad, right? They don't steal our ID, they don't go to Mexico. They give us energy, and that's my main point about carbohydrates. An apple is gonna digest the same way as a Snickers bar is gonna digest. It's the same amount of sugar, right? Like, no, we can't eat, we may not wanna eat donuts all day long, but do we wanna eat carrots all day long either? No, you're not gonna get the nutritional balance that your body needs either way. So I love when people give me the challenge of like, Jen, I can't eat pizza all day long. Well, I agree with you, because you're not gonna get those nutritional benefits. You're only getting that one thing. But you can't eat fruits and vegetables all day long without the fats, the proteins, the carbohydrates, because that's what makes our body go. There was this study that I love sharing about fruits and vegetables and salads, right? What's the main purpose for a salad? What? Roughage, right? Like, what'd you say?
Usually it's dressing.
Dressing.
The cheese.
Remember that, okay? Remember that, right? So people generally have salads to get your vegetables in, right? So there was a study done, so people had the same salad except the dressing was different. So they had low-fat dressing, light dressing, and regular dressing. Roughage has vitamins and minerals, right? So we're trying to do a good thing for our bodies. We're trying to get vitamins, minerals, and to be healthy. However, the people with the fat-free dressing absorb the least amount of minerals and vitamins because there are fat-soluble vitamins as well that people forget about. Fat-soluble means that your body literally needs fat in order to absorb that nutrient. Carrots is a good example. Carrots have vitamin A, fat-soluble vitamin. If you don't have that dressing, why are you eating salad, right? It's not the best thing in the world, right? There are great salads, but would you rather be eating something that makes your heart and your brain and your stomach happy rather than just, yeah, right? Rather than just feeling full from fiber and then feeling like you need to watch the Food Channel all night long to get that little bit of a rush, you know, of, oh, I wish I could do that. That just makes you miserable, right? Fat is also super important. Fat does not make you fat, number one, before I finish that sentence. Food is not inherently fattening. Food does not make you gain weight. It's portion size and also just stress and medications. And fun fact, so 96% of diets fail. When fail, the goal is weight loss, right? So 96% of diets will actually cause a weight gain. So that's a 4% success rate. Do we take medications that have a 4% success rate? No, right? So it's just that idea of educating. What is the actual nutrition science that makes our body happy rather than what people are trying to make you spend money on? And then protein. People typically don't have a problem with protein. It's needed to build and repair muscles. It's the building blocks of our hair, skin, and nails, and literally everything else. It helps support our immune system. Fat, going back to it, it also helps our reproductive system. So when we talk about puberty, fat helps us make estrogen. Fat helps us make testosterone. Without the decent amount of fat in our diet, we're going to have a hard time going through puberty. Just like calories, just like pretty much anything else, because your body's just not getting what it needs to grow.
Can I ask you just said most people don't have a problem with protein? Is that because of the volume of meat? That's our challenge in our house.
Oh, yeah. Yep. So you'll have this.
Protein.
you'll have the individuals, right? So most often, people won't have a problem with protein that I see because protein is more associated with diet and gym culture, that the more you can get, the better, right? And they typically will feel less guilty about having a protein source, where there are people who, that's their struggle. No, I will not have it. And it just depends on that person. Some people are completely fine with carbohydrates and they'll eat cake and Snickers bars all day long, but when it comes to beef, that's where they restrict. They're like, absolutely not. So you have those two very different sides of someone with an eating disorder, right? It just depends on that person. And if they're, go ahead.
No, just like,
You're
give
just,
me something.
you're absorbing it all in.
Because I don't understand it, and I wonder, I think we all, I'm not making assumptions about anyone, but anyone who has a child, you're gonna be like, what did I do, what did I do, what did I do? And our household has always been kind of like, probably protein focused. And I don't know, I can't figure out what it is about, we're making progress now,
Yeah.
so that's good.
I'm so glad.
But I just feel like I want to understand what this protein avoidance is.
Yeah, I don't really know without talking to somebody, you know what I mean? But it's so interesting too. Well, one, I always want to point out to parents that it's not what someone did or what someone didn't do, because sometimes there's no avoiding it happening. So there is no one blame to someone having an eating disorder, just like there's no one blame to someone having schizophrenia, or there's no one blame to someone having OCD or anxiety or depression. It's just something that's going on, right? And that I would say that may be a good mixture of therapeutic and nutrition, because there is obviously some part of that food that is so anxiety provoking. So there's something in there that's directly food related, but you also have the therapeutic side where, who knows, it may not be, right? So it's so hard to really try to understand, because for people who haven't gone through that, or for people who haven't lived that same experience, you may never really truly understand. But the best thing that you can do in what I see is support. So as long as you're supporting, as long as you're involved and it's positive and you're making progress, it's the best thing a parent can do, at least what I feel like. Research has shown that when parents are positively involved in their child's recovery, they actually have a longer recovery than someone who may not be so fortunate to have that parental support. So relapses are more common for people who don't have parental support than people who do, but you really can't gauge when someone is really going to do better or do worse. Recovery is not linear. Oh, look at that, a segue. So I wasn't sure if I was gonna use this or not. I just brought it in case. It's a recovery model. So again, recovery is not linear. It goes up and it goes down, and there's 4 different phases of recovery as well. It's a mix between, when behavior starts, where therapy begins, where there is denial, a need for habits, and then once there's progress, you'll see like symptoms come back, and then symptoms go away, right? Even when you feel like you're going in one direction, you feel like you take steps back, but it's just part of the game, not game situation. Questions?
So I'm just skipping a couple slides.
I'm skipping a lot of slides.
So in regards to this, treatment and recovery looks different for everybody. So, and it also kind of depends on like what stage they're in of their eating disorder when they come to you. There's a lot of different factors. Support is a huge factor, and something to remember is that like improvements and change are not going to happen overnight, as I'm sure you have experienced, and it's very frustrating. And Jenna's exactly right. There could be a variety of reasons why people fall back into those unhealthy but safe behaviors for them, whether it be a triggering event, a transition. We see a lot of that fallback, like with going to college, moving, starting a new relationship, a traumatic event, anything that feels unsettling, they will revert back to those safe behaviors. It's safe for them. It's unhealthy, but it's safe for them. So that's something to keep in mind. It doesn't mean they're failing. It doesn't mean treatment is failing. It just means like in those moments they need a little bit more support and reminders of like, okay, hey, we've been here before. What worked? What didn't work? Where do you want to go from here? So that's something to keep in mind because again, like I recognize, as I'm sure you know, it's very, very frustrating and you might feel helpless and hopeless, like what am I supposed to do? My kid is starting to, you know, fall back into those old patterns and habits. It's okay. And then also remembering full recovery looks different for everyone. And I find that it takes a lot of maintenance. So after several years of being in treatment and maybe they say, okay, I'm in full recovery, it's still maintenance because they will never be able to look at food the way that someone who has never experienced disordered eating looks at it and thinks about it. And they might have to do some check-ins every now and again, and that's okay. So that's just kind of bouncing off of that, just lovely visual.
And so you reminded me of another research study that I read. So Amy just mentioned that people may not be able to look at food as people who never had an eating disorder or disordered eating habits may have, right? So research actually shows that the people who go throughout their day, eat their meals, eat their snacks, wash their hands clean, go throughout their day without thinking about food or their weight, those are people who are only going to fluctuate maybe 2 pounds in their whole entire life. So I always will tell people, you probably know people who it seems like they have no, and they don't even think about food until their meal, they go and they move on, right? They stay the same their whole life, no matter what size they are. And it's more likely for people who yo-yo diet or go through different fad diets, Weight Watchers, keto, paleo, the blood type diet, whatever. Those are the people who are going to fluctuate their weight more so than people who wouldn't otherwise. So it's just so interesting that you have these couple different types of people and their brains and their bodies just work in different ways based off of how their brain just works, which is wild.
Yeah. There's a lot of
Psychology,
science.
yeah, there's so much, it's wild.
Yes.
Can I just interject, because you're me, okay, so my oldest son is what you just described, like he just eats, and then he's full, and then he walks away, and he's just, you know, fine with that, he doesn't like snack, he doesn't overeat, he has no seeming, like he doesn't seem to have any issue with food. And then my middle child, who is the one I cared for, sees that, and is like, why don't I look like him? Why can't I be like him? You know, and so that I have the exact opposite, following him, living in the same house, thinking he needs to look a certain way, and that is another piece.
And comparison is huge, and I
Yes.
always will go through that. That's more of your therapist kind of a situation, because it is so common for people with disordered eating habits to compare to other people. Like when I am in groups with adolescents, I have heard numerous times like, how the heck can someone be normal around food? And I'm like, well, let's not use the word normal because everyone has their if, ands, or buts. But it's just like completely night and day sometimes with how they compare themselves to others or how you can compare to people, even people who have been raised in the same household, right? So that's another thing, like, you just can't blame it because sometimes there's no rhyme or reason.
And I think in that instance specifically, that psychoeducation piece would be so enlightening for him just to hear like, oh my God, my body's in starvation mode and that's why I'm not able to look like this or feel like this or do this. And as your body continues to be in starvation mode, your metabolism slows down because your body is like, wait, as soon as I get food, I have to hold on to it because I don't know when I'm gonna get it next. So it changes everything.
And you can be in starvation mode in being in a higher weight body too. So like, I do not use the words underweight, overweight, or normal weight just because of how the BMI is. So the BMI, people traditionally strive to be at a lower BMI, right? Like you go to the doctor, like, oh, your BMI is whatever, right? Like, blah, blah, blah. People with a BMI of 27 to 29 are people who have been researched to live longer than people who may be at a lower BMI, closer to 20. So it's just interesting how we phrase certain words of being overweight or underweight, where overweight is technically a live longer range. So I don't use overweight or underweight. But you can have people at a higher weight body who have anorexia and be malnourished. So it's just interesting, like the stigma of you don't know how anyone's body is responding on the inside with how they look on the outside. Like a lot of people will be in denial about their eating disorder because they're of a higher weight body. It's really interesting.
And that kind of brings me to something I forgot to bring, because of course I did. I have something that I have been working with clients on for a long time is they are so triggered when they go to the doctor and the doctor's like, get on the scale. Like, you don't need to be weighed. You don't. And I have, you don't. I have, good. I have little business cards that you can bring to the doctor and hand to your doctor without having to say anything. And it literally just says, please don't weigh me. And if it's absolutely medically necessary, please explain to me why. And it's very trauma informed because a lot of doctors are missing that trauma piece of if I step on the scale and I see my weight, things are not gonna go well. So that's something to keep in mind, and for you all to be able to advocate for yourselves and your children, because what Jenna said is exactly true. If someone in a larger body walks into the doctor's office and they're like, you're unhealthy, you need to get on the scale, you need a new doctor. So, just something to
That can be pretty brutal sometimes. Just from my small experience, working in hospitals or clinical settings I was in, doctors like know nothing of this. They're very ill-informed on nutrition and health and therapy stuff, and that doesn't mean they're necessarily not willing to interact, but it's like, you know, like Reader's Digest is where they get their information, how little information they have on so much of what you're sharing tonight.
I do, so we both know the same doctors.
And there's exceptions, sorry, I shouldn't say it, but in
Of
general,
course.
from my small experience.
No, yeah, we know the same doctors who specialize in Western New York or Buffalo. I have some of their cards. Dr. Candido and Dr. Paget are two doctors in Buffalo that specialize in eating disorders. But I have seen like a lot of doctors now are really accepting of these conversations. So when I have my patients who really struggle with their weight, I just call the doctor and talk with them and kind of tell them why, right? And I've actually had a lot of success with doctors having open conversations and learning both ways about a mutual patient. So it's as long as someone is open,
Yeah.
it's a really interesting conversation. So I will always say, like, to be in this field, you have to be a lifelong learner because you can learn from your patients as much as your patients can learn from you. Sometimes it's more my way or me learning from someone else. Because a lot of the times, these kiddos are smart. Like, they really do their research. They just latch onto the information that seems to help their maladaptive coping skills.
For the sake of time, I do want to just make sure that we have some time to just open up for general Q&A. I have some questions just to start, maybe to kick it off. So thinking about both in like the school setting and then maybe at home, like what are like, maybe this is too specific of a question or hard to answer, but like what are like 4 to 5 or 2 to, like just some basic tangible things to do or not to do, either environmentally or just kind of those basic, even like what you were saying about should I focus on, are these things, should I work with my child on being able to read a nutrition label, or is that like, what are like a few things maybe to do and to not to do, like for sure where it's like this is definitely something that would be problematic, especially let's say as an educator, having in your school building or having in the classroom. And again, like obviously there might be wiggle room here and there with certain things or it might impact people differently, but just what are some of those like few things where it's like, man, this is really like not a healthy thing environmentally to have going on in your home or going on in a school building, things like that? or vice versa, like, these are some really great
Do you
things.
work at school?
Yeah, so I'm the coordinator of the Family Support Center here in
Oh,
Clarence.
okay.
My name's Evan.
Hi.
And,
So he'd be in contact to get in contact with like the school, but, yeah.
So if you look at one of the, did I give this to everyone? Great question, Evan. So this just talks about what parents can do to promote positive body image. So you can, again, you can go through this kind of on your own. But really like fostering an environment that builds positive body image, whether you're in a larger body or a smaller body or whatever that looks like. I think the main thing is just being open to talking about it. And I can't tell you how many people come to me at the age of like their late 20s or 30s and we talk about, you know, what was the conversation around food with your family, what did dinner time look like, and almost always it's I had to sit at the table until I finished my food, even though my hunger cues were telling me I was full, or my mom was always dieting, no carbs in our house, just food rules like that. I would try very, very hard to kind of veer away from because it's a learned behavior. And even if it doesn't make any sense to the kid as to why am I not eating X, Y, and Z, it's a behavior that was learned and that was implemented. So I think that's the main thing to keep in mind for home things. Do you have any thoughts for school?
So there are some things that are unavoidable, right? So what is unavoidable, unfortunately, is diet culture, is word of mouth, right? Everyone is always going to have an opinion. So the ability to, at least at school or being role models as adults, is really just enforcing like, hey, you're growing. People who are growing really just need nutrition throughout their day. There is no specialized nutrition information for anybody. So like say if you're looking at a vending machine, right? Actually I had a patient who came into my session and she looks at me, she says, I have a present for you. I'm like, okay, what's my present? And she gives me this piece of paper that she folded and she ripped the thing off a vending machine, and it's like the average, I'm going to say a calorie number just so everyone knows, the average adult should have around 2,000 calories a day for a healthy diet, and she ripped it off. She's like, I can't see that at my school anymore. I'm like, why did you do that?
I love that.
Right? I'm like, power to you, girlfriend, right? Like a calorie number is so triggering when it's general nutrition information, because for some reason, and I guess we can all feel as adults, if someone is telling you something in regards to your health, and it may be the government or someone of a higher authority, you're gonna believe it, right? So it's like, it may not be, for some people, it's just data, and they're like, sure, whatever, I could care less what that means. But there are other people who are like, I really care what that means, I'm not gonna do anymore. I've had a patient who, she was in her late 50s and she was doing anorexia recovery for quite a long time. She could only do a certain number, right? So she couldn't do a number over. And sometimes its numbers are super triggering, sometimes, oh, you know, the way I look today, I look pretty fat, right? Like just being down on yourself, maybe we don't need that negative language, right? So I guess it's just more education on how beautiful your body is and what it does on the inside and the outside, rather than being so harsh on ourselves, which is really hard to do, right? And I will always tell people, I think therapy is a wonderful thing. I think everyone should do it, right? Because you just learn so much about yourself just by talking, and I'm a big talker. Once I get warmed up, I don't shut up. But like in a school or at home, right? Maybe not focusing on calories so much, or maybe just kind of understanding that everyone has a different thing. Like there are some people, medically, they have to, right? Like say they have a heart condition, sometimes they just have to as adults. And I'll have to tell kids all the time, like what you do, what your parents do does not mean that the other person has to do it. Because there is no general nutrition guideline. There is, but it's really not for everybody, right? It's all individual. So like, if the kid comes up to you and says, well, what should I do? You do what you need to do, right? They may not know what that means, but eventually with support, they will know what that means. I truly believe that people really just knowing their resources and knowing verbiage that's more supportive rather than negative, I guess, is best for everybody, because you really can't avoid everything. Because it may not be going away, but that's where the education part comes in, right? I mean, like, man, I can't believe that commercial did that. Like, I can't believe that commercial said that you have to be X size or whatever. Like, what is that I Do You commercial on the radio? So catchy, so dumb, right? like those little things that we start to notice, once you start noticing diet culture a little bit more, just kind of talking about, man, that's so interesting. I wonder why people think that, or I just feel so bad that that person has to feel that way, right? Like sometimes that change of conversation and change of how we see the world is what's a little bit most helpful. Did that make sense? No?
Yeah.
Yes? Cool, thank you.
Have there ever been any like in-service for teachers? to
So
understand?
so beginning of last year, we did have, NARS,
Yeah.
come in, for our opening day, like professional development for staff. And it was really great, and hopefully we can have more of that. I know our, kind of the just people at district office that will be organizing our next opening day PD are gonna start reaching out to people, and I've obviously given them a list of
The
a
other
few.
thing with that too is teachers have to get CTLEs every year. It's mandated by New York State. We're working on getting like things like this CTLE certified. So that
there's a
way they
little
at least have a reason to come.
Yeah, so there's a little more motivation, 'cause, I mean, that's the tough part with any of these areas that are like niche, and I hate calling it that, but it is, right? Like, any areas that are more, I guess the better word to say would be specific. It's tough because it's a time thing, right? So in the scope of like what a school staff needs to, let's say, get professional development on, it's sometimes harder to find time or carve out time for these things, because again, talking about like macro picture, right? So from school districts or even a community, if you're talking about even how does a community as a whole address some of these issues, okay, what percentage of our even family support center referrals, so our referrals represent, so if we've got 300 referrals this year, we have about 4,400 students in the district, so you're talking about less than 10%, okay? Of those 300, I'd have to go back to our data, but let's say 20 have been for eating disorders. So you're talking about a very small percentage, but I would go back to the point of prevention. So even though we've only received 20 referrals for eating disorders, by that point those kids have an eating disorder, or a very high likelihood of an eating disorder. How many other students are on that path and are maybe 1 or 2 or 3 comments from a teacher away, or comments from their parents away, or whatever else, or a traumatic event from leading to them kind of going, and that could, whether it's eating disorders, whether it's other forms of mental health concerns. So it's tough because on one end, from a macro level, it's a very small percentage. So in terms of allocation of resources, is it worth it? But then when you think about the level of crisis when if you have a student who's dealing with an eating disorder, in particular, let's say, or any other mental health concern, but an eating disorder in particular because you're dealing with potential hospitalization and a lot of other issues, that's a kid now that's potentially out of school for 3 months. How do you provide that education? How do you provide that instruction? That's extra work now that that teacher has to do to make sure that that kid's being educated. And so the trickle-down effect is quite substantial for the district. So that's kind of why we're trying to do these types of things. So there's hopefully going to be, to answer your question, more professional development opportunities. It's just a matter of, we marketed this, not a lot of people showed up, but I understand it's 7 o'clock on a Tuesday at the end of the school year when people are kind of burnt out anyways.
But I have to say, as a teacher, I think this is a good thing, because the things you point out are like, I'm not going to address a child about it, but I'm going to go to guidance and say,
Yes.
this is what I'm seeing, and because they're the ones that are going to do the follow-up.
Right.
Do you know what I mean?
And
Then it's the power, you're empowering the teachers for more information.
Yeah.
So here at Lockport, I'm very familiar with Lockport. There's a lot of food insecurity at Lockport. So that is
Yes.
like a whole other level. If you have an eating disorder, mom and dad can't afford to go to the grocery store because we don't have transportation at the nearest grocery store.
Yeah.
So I think for you to be aware of this is huge.
And I never realized that until years ago. I did a long-term sub position there, I'm talking maybe 10 years ago. And I was just, like, it blew my mind. And it's like, you know, sometimes those are kids who do something in class, they're the ones saying, like, I'll take that extra. You know, and you're like, okay. So, yeah, you know.
How do you as parents see the schools affecting your kids with what they're dealing with? Do you see any effect?
Well, I have to like give props to the Clarence School District for being super supportive, especially like Doug Dermott, it's been amazing. He actually was the one that helped us kind of get to where we needed to get to for her anxiety. He started with anxiety and we went down that road. But she has actually advocated with specific teachers when assignments have come out, because she's in a place where I think it's easier for her to advocate for other people than to necessarily, like this was even before she had accepted the fact that she's in the denial stage. But there are some things, like assignments that have to do with keeping track of what you eat and how many calories and what the food groups are, don't need to be done.
Oh, like that was like a nutrition class or something?
Calculating your
Oh.
BMI in gym class does not need to be done.
Yeah.
Having math assignments that have anything to do with calories and like doing math that has to do with food like that's not necessary. So those types of things, like they're very, they're sporadic, so it's not like there's this pervasive issue. But I feel like if teachers knew that like those things can be extremely triggering. And if you can just, it's so easy to avoid it, just don't do it, like, in my opinion, but, I'm not a teacher.
That kind of speaks again to this, you're a parent who's dealing with it.
Yeah, I deal with
So
it,
it's,
every
and that's
single
where
moment.
it goes back to,
Life right now.
it goes back to this, the idea of empathy and the idea of like having an understanding that even though, like those assignments, like as a teacher who has taught health classes before, like I'm guilty of that,
Mhm.
and.
But you weren't aware, were you aware it could do such a that?
Well,
that's
I
right,
mean, obviously I was
awareness.
aware of eating disorders, but we're talking,
Yeah, but the trigger. that's-
yeah,
it's
and
just
I think so again,
awareness.
it's being open-minded enough as staff to listen to information, listen to potentially a parent or a student's life experience, and maybe consider how you might need to alter what you're doing moving forward to address that. And so I think that's kind of, I guess my pitch too, from a school staff standpoint, would be as a parent to also give some grace to the school or the family, and I'm not saying you didn't, obviously, but to give some grace to the school or the family too, because like they're learning too. If you have someone who has been, let's say, teaching for 20, 25 years, again, that state eating disorders or anxiety or anything else wasn't a problem 20 to 25 years ago. But like the world has changed, it is different, and some of those people might not have the education, and that's not necessarily like entirely their fault, right?
No, and the
It goes
science
down
has
to
changed too.
what you said, which is professional development, and so that's kind of what we're trying to offer. But I want to open up for other questions too.
Sorry.
No, you're good. So, we have, obviously it's 8:30, but I want to, we want to be respectful of your guys' time, but are there any other questions?
Think of that stuff unless someone like you told me.
Yeah, and there was even like, I pulled her out for a few days when they were showing a video that had all to do with, it was like,
Supersizing it?
it was like Supersize Me, but it was a different one, it was during the Clinton.
I've heard a lot
time,
about it,
and,
yeah.
I just pulled her out because she came home, she's like, she actually, thank goodness she advocates for herself, but she walked up to the front, she's like, I can't stay in this room. Good for her. And then I contacted the health teacher and discussed it with her and said, how many days are you showing this video? It was near the end of the school year, it wasn't even something they were gonna be casted on or anything. Just kept her home. And said, she's not gonna be in school for that, that's what you're showing.
You just don't know, you don't know. You know what I mean? And then it's parents who know and advocate is what's really gonna help, I feel like, because it's helping change the times, right? Because you are absolutely right, like, people who have done their job for a certain amount of time, just do the job, right? But you are right, whereas nutrition science has changed. Nutrition is the newest science, and 20 years ago, it's different than what it is right now because of longitudinal studies.
So that's when my daughter was diagnosed, I came into it with a ton of assumptions. Like, oh, I know what anorexia is, da-da-da-da. No, I didn't. I didn't at all.
There's, I'm actually gonna hand around this. I have a really awesome handout that I did not bring with me today, but I have it digitally. It's how parents can support their child at the table and just like provide supportive language, and it'd be really
Yeah,
good for
and that,
teachers
like
to.
those tangible supports, like I said,
Like
you know,
email.
we can, I think this is an indication, even though it's a small group, these conversations need to be kind of continued and had. Does anybody else have any, I want to be respectful of their time as presenters, does anybody else have any other questions, generally?
I handed out a flyer, feel free to contact us. If you have ideas as professional staff and you're like, this is needed, this is where I'm lacking, please reach out to us. We have a budget. We want to use it not just to serve our families and our students, but our faculty and staff as well.
And as parents, yeah, if there's professional developments, things like this. So part of the reason that we wanted to do this too, at the library, let's say, as opposed to at the school, is because there's a community aspect of this, and we want these conversations not, it's great that the school is able to provide these types of things, but we want to be having these conversations also like within communal spaces as opposed to just the school buildings, because there's people more than just our students that can be impacted by this, and ultimately,
It seems like that maybe even like a starting point would be not even like all teachers, if you had to start like gym teachers. Like I remember doing my BMI and I was never overweight, but it always came out that I was like overweight or something like, and it did, and then, you know, I went into dietitians and that dietetics and I studied. But I remember when I was a teenager pulling all the cheese, or as a college student, pulling all the cheese off my pizza. My parents would be looking at me like, you're crazy, drinking skim milk and all those. Now I'm like way past all that. But those little things, you know, and I wonder, did that BMI thing, you know, little things like that, did they maybe trigger me at some point and I didn't even realize it?
Psychology is wild.
Yeah, you know, so.
and I think that's where, you know, the conversation that we wanted to have too, of having both the dietitian and kind of the food science end of things, along with the therapy end of things. Because the fact of the matter is, like, we're not going to change food labels overnight in Clarence. Like that's, we're not going to change a lot of the, whether it's eating disorders or any other mental health concerns that we're talking about. Those are big system changes that we're not going to be doing. But
Start with a little change, like a gym
Well,
teacher, stop
starting with those
drinking
things, but
you know.
also starting with what as an individual can we help our kids do, and part of that is like developing resiliency and coping strategies, which goes to the therapy end of things, because as Jenna said, at the end of the day, like, there's some things that are going to be unavoidable. Like, we can't totally control whether or not someone's going to get bullied, or whether or not there's going to be a BMI assignment. Hopefully we can change that over time, but the fact of the matter is, it might not change, but what can change is how our students and young people are equipped with tools to kind of deal with those things that are triggering, so it doesn't lead to a more significant